Town of Hadley Ambulance Oversight Committee. And do we need to do introductions or? Yep, we're good? Okay. So with us tonight, we do have our folks from Action EMS. So we have Mike and Robert are with us this evening. So you want to start out with old business and talk about the...
You can go out of order if you want,
There's-
if you need to get out of here
You
sooner
okay
than
with that?
later, or whatever.
No,
so
it's
you can
totally
go
up to you in terms of.
You don't have to sit through all this, it's totally...
Don't mind.
Okay, great.
Okay. Yeah, well, so why don't we jump to the reimbursement?
Sure.
That's your first.
Okay.
Okay.
I can jump. I'll even make the leap and say, I have the check.
Final
That's
check.
that's the balance of the reimbursement that's due. So I think everyone is aware
Thanks to you.
that the rebate that was earned during this last year, and I actually have the printouts if you. I don't think I have enough for everyone, but.
Okay,
I'll
we can
pass it
share.
around. The rebate that the town earned for the fiscal year ended June 30th, 2024, was $141,000. When we added that into what was left from the fiscal 23 rebate and offset with what had been remitted to the town previously, that came down to a balance due to the town. After taking into consideration the subsidy dollars that would be paid in for fiscal year ended June 30th of 25. So we netted everything down. This was based on conversations with a couple members of the committee. Netted everything down to a net check due back to the town of $36,000, $36,247. That takes the town through June 30th of next year. So no dollars are due for subsidies to Action through the end of the current contract year. So, good job.
Could we ask a couple of questions about the... So, and again, maybe just numbers tell a story here, but a couple of things that we were curious about. One is the call volume during this period relative to prior periods. And then the other thing is the collection rate seems to be down.
So I'll let Mike speak to call volume on the system. Collection rate, and I don't have the exact numbers in front of me, is based purely on how much we're able to get in from the insurance companies, from Medicare, Medicaid, and most importantly, or most difficultly, from the individuals who have a deductible copay left over at the end of the whole process. We are constantly reaching out to not only the insurance companies, but also the individuals to try to get, you owe us X. Sometimes we have better luck than other times. I know that there have been certain instances we've had to file small claims against individuals. Just because we win a judgment doesn't necessarily mean that we collect on it. People unfortunately often do it's a medical bill. I'm not paying for it. I don't need to refinance my house. I'm not trying to buy a car right now. I'm not worried about an outstanding debt. We have 1, 2, 3 in-house collectors, so people working on collections in-house. One who works a lot with denials, insurance, and tries to get the insurance companies to pay more. We have 2 other individuals who both work with one focuses with insurance companies and individuals, and one with individuals directly. And then we still use an outside collection agency, and they're calling, any patient account that we place with them, they'll work for 7 years trying to collect on that. Unfortunately, we can't always control who's going to pay, when they're going to pay. Insurance companies, we do have fairly good success with. And I don't know Hadley specifically, but commercial insurance overall, we're between 78 and 81% is what we end up collecting from them, which is, I think, a pretty good response from the insurance companies, because they're more often than not to say, well, we're just going to reprice you, and we're not going to pay what you think you are due. So we have had good luck with the insurance companies. Medicare and Medicaid, we're typically in the 91, 92%. There are some denials that come back in, but we do have good luck with Medicare and Medicaid. And ultimately, it really comes down to people not wanting necessarily to pay the deductibles or their co-pays. And that's what we end up chasing.
Is that from the time Mike and I were just having a conversation the other day, it was more, no data in front of us, but just in memory. When we first went with Action, and we were, when you were looking at the numbers that we had when we were still working with the town of Amherst, one of the things that was highlighted was that the Amherst collection rate seemed pretty low relative to, I'll call it industry standard. And they had been doing it in-house, and then they switched, right, went with the third party or whatever, right around the time that we switched over. But it just, Mike and I were thinking, it seemed that your collection rate was initially higher than it seems to be now. And you may say, you just made that up, Molly. I don't know that. It just seemed like the numbers now were lower than when we originally started. And have you looked at that at all, or?
I've not looked specifically at it, but you didn't make it up. Okay. But we found that typically municipalities, when they work their own, they have a tendency to write, they'll work things for 90 days, and then they just either write it off or they'll send it off to a collection agency. And the collection agency is not necessarily going to pursue collections or payment as hard as you necessarily you'd like. Our guys will work stuff for up to a year, sometimes 2 years, before we send it off. And if we know that we have a viable account, we'll continue to work it. We'll work with the patient, say we'll enter into a payment plan with you. You owe us $1,000. We'll $10 a month. Fine, that works. We'll do stuff like that. Collection agencies may or may not do that, and they may give up on stuff. But we'll keep reaching out to patient contacts. We've added into our repertoire sending out text messages to patients with their bills and asking them to contact us. We don't get 100% results from that, but we do get results, and that helps too. As far as specific collection rates in a community, it can be very variable.
It depends on the mix of.
It depends on the mix, and it depends on specifically the mix of who hasn't paid at what point in time. If we did all of our transports on, as an example, all of our transports were on the last day of the fiscal year, well, our collection rate would be 0. But as soon as they start moving back, like older,
Loaded, yeah.
there's a high, I'd say a higher likelihood that we're collecting something on it. But it all depends on what those were. If they're all Medicare and Medicaid, our collection rate's going to be higher, but it's smaller dollars. If it's commercial, it'll be lower, but there's a chance that it'll be higher dollars.
Would you have the records where could you just go back and
Yeah, we can generate the data and do a
that-
comparative analysis. One thing I've noticed with call volume, and I think it's with the construction, you're doing less motor vehicle crashes and transports in the system as a whole. There's not as many that are occurring because everything's going at a much slower rate, so that's an impact. One thing we are noticing is the Amherst swing. So, and that's going to play out in future months here, is that we're going to Amherst a lot now. So,
which is a good thing.
Which is a good thing, right? So that's going to move the needle. That's really the biggest variable that I'm seeing is the MVCs are down a little bit, and then now the Amherst stuff is starting to come back. So, and then the last thing
Actually a good
is,
thing.
yeah,
I'm glad they haven't put the suicide lane in yet, so we can keep them down a little bit.
right? No, but seriously, but that's
Suicide
having
lane,
an impact in terms of volume and revenue in the system is when we do that.
So, can I ask a question? So in these motor vehicle accidents, are you going after the insurance of the vehicles and not necessarily medical? Are you doing both? Are you doing medical and car? Because lots of times with those two types of insurances, they will have you go to the car insurance to get reimbursement instead of medical.
Yeah, so
are you finding that you're having to do that?
Yeah, statutorily, Joyce, you have to start with the PIP side on the motor vehicle coverage. However,
Yeah.
what happens is that if they exhaust the PIP coverage, I think it's $4,000 and then $8,000 of the numbers, so up to $4,000, after $4,000 PIP is exhausted, then you can go to the commercial insurance. If they're on Medicare or Medicaid, then they can go up to $8,000 in coverage, and then Medicare and Medicaid will kick in after that. So we do follow that, it's a statutory, we're required to do it that way.
How about there are a lot of people now, and I know through working in the office medical, that most patients today have secondary insurances. So are you also going after when people have Medicare A and B, or they have Medicaid, not Medicaid mostly, though there's straight Medicaid, but Medicare A and B, most of them have secondaries also. So are you doing the secondaries also?
Yeah, so the data systems search for that now. So when we upload a claim, what happens is, we can tell, there's a few things that we can tell with the system. We can tell where they are with their deductible spend, and if they've got active coverage. If they haven't finished their deductible spend, what we do is we hold that claim until the deductible is hit. Sometimes it's deductibles that are specific just to ambulance, so they won't hit that. So we're talking about total spend on the policy for the deductible. Then when that deductible is met, then we will release the claim so that we get full payment and not have to fight for the actual payment cash from the individual. The other thing that will go on is that Medicare and Medicaid, we have crossover dollars coming back to us where Medicaid is now paying the Part B copay. And and so an ambulance is Part B only, there's no Part A coverage at all. So you can't even touch Part A side of the benefit on Medicare. It's strictly, and then the downside to Medicare is Medicare only pays 80% of the cost of the bill, of the allowable amount. So then you get into this debate about how aggressive do you go after the elderly who are on those plans, where that payment's probably about $80 in the end for that. So a lot of that ends up getting written off in the end. But by federal law, you have to send the claim to the beneficiary. You can't not send the bill to them. You're required by federal law to do it.
Okay. Thank you.
Yep. Last thing I want to say, Mike had sent me a couple of things I just want to mention about people that insurance isn't paying the full amount of the invoices that are being sent. So it's typically the similar insurers are doing it. It's the Cignas, it's the Uniteds. So when Mike sends me those, and I owe Mike some follow-up, but this is kind of the follow-up, we reach out to the individual, and typically what happens, the individual is not working with us or communicating with us to get on the phone with the insurance carrier to reprocess the claim, and that's typically what happens. And they usually sometimes wait months, 6 to 7 months out before they even start engaging. They just think it's going to go away. So Mike sent me over the past 2 weeks 2 instances. One of them's already reprocessed on one of the cases, and then we've already reached out to the other individual. And what we like to do is set up a conference call with the insurer, the claimant, and us, so that we can walk everybody through the process. And then typically most emergency services are covered by state statute, it's just a question of what the plan turns around. The plan might say for ambulance, even though you have a plan deductible, you might have a separate deductible on ambulance too. So that's confusing as it's its own confusion.
Yeah, we had a couple requests for a review of their rates based upon the call and stuff, so
Yeah.
I passed them on to Mike, and then if it does come down to a point where we want to discuss waiving it for the resident, it comes back to the Oversight Committee and we would ask. But a lot of times...
In one of these cases, I might come back to you about that.
Okay.
Okay.
Some of them have been, though, it's a coding issue, I think you told me a couple times. like-
Sometimes it's coding,
So-
sometimes, a lot of the insurers automatically will, what they'll do is they'll send an explanation of benefit to the beneficiary and say, hey, we got this bill for $500, we're repricing it to $250 because we renegotiated this rate on your behalf, and you don't owe the vendor any more money. Very deceptive, misleading type of information that's being passed on to the beneficiary, and then we have to get back and say, no, that's not true. Well, they'll be like, no, this is the letter. See, they negotiated for me. I said, no, they just don't want to pay the benefit. And we've even had people file complaints with the state insurance commissioner.
Cigna
over
was
it.
notorious for that.
They still are. And United, just,
Oh, United is awful.
Yeah.
Oh,
yep. So usually when Mike sends me those, I can say, it's Cigna or United, and then I'll go in the system and say, yeah, that's probably it.
I just have one last question. Mike, are private ambulance services allowed to file for that state reimbursement to try and recoup some Medicare, Medicaid? No, that's
No,
just
there's-
private or public ambulance providers?
There is nothing out there in a pool that we can apply
As a
offset
private.
funding,
Okay.
right? Yeah.
Amy, did you have questions?
How about uninsured? Do you find that there's people that don't have any insurance?
Yes, there's still a percentage of the population, it's not, they're rolling the dice, they're not carrying any coverage at all. And typically, what do we get, 2%?
I'd say 5%, but yeah.
Probably here
yeah.
because of we have a couple of, we have that hotel with folks that I would probably assume are probably a high incidence of not having insurance. So Craig's Doors, they're all, the
Yeah,
homeless
and-
shelter we have.
And sometimes what happens is people were once on Medicaid, and a lot of them end up having, suffering from mental illness, substance abuse disorder stuff, and they never renew the benefit, because they have to renew the benefit annually. So we've actually gone so as far as to help them re-enroll, and then the coverage becomes retroactive, but tracking people down sometimes is absolutely impossible.
Which usually happens at the hospital. You get transported to the hospital too. Social services will step in.
They will try to, yeah.
Try and re-enroll them.
But some of the
Good.
clients, they
Good.
can't do it,
Yeah.
because they just aren't engaged enough to do
Mhm.
the enrollment process.
Right.
So it's a little frustrating. So, yeah, so there's still a percent of the population that's not having any coverage at all still.
It has been improved, I can say, responding to the site because they've really been working hard on trying to get us the cover sheets, right, Evan?
Mhm.
So we'll
Yeah.
have information on who's staying there and stuff like that. So we have some base information. So I think that's starting to improve. They've been working hard on that stuff.
Yeah, we can search all the data systems with name and date of birth. We can tell exactly what they have for coverage and if it's
And that's
active or
the
not.
days in there, Mike?
What's that?
That's at the days in?
It's the old Econo Lodge.
Okay.
How about students? And most of those have insurance, and that's not an issue for
So
collections?
to be enrolled in the school, they have to carry insurance. They either have to show proof of insurance or they have to buy the college's plan.
Right, and
Yeah.
so you
Waterbury.
usually collect on that because it's,
Yeah.
okay.
Now, the UMass stuff is relatively new, so some of it's not aging through the system yet, because it's, I mean, what are we talking, 2 months now, not
I was
even?
gonna say, yeah.
I mean, barely, maybe 45 days that we've started hitting calls there. But it's almost daily now, too. But
Good.
on average.
Up and
because
down, yeah,
sometimes it's
weekends a
3
little bit
day.
more, yeah.
The overnight, we did a bunch, so it usually comes in at like 1 in the morning, I think is when they're
And that's when
going.
everybody's finally getting home.
That sounds about right, yeah. Bars are closed.
They're closing up. So,
Now, some of this that you're saying that you're not getting is because of co-pays and the deductibles, but if you charge a certain amount and the insurance company says, no, we're only paying this, and so the amount that you're not getting, is that in your calculations? And I'm thinking, are we charging too much?
It has nothing to do with the dollars you're charging. It has everything to do with what the insurance company wants to pay based upon their profile.
So do they pay a percentage, or would they pay, this is all they're paying? So if you said,
There's
well,
no rhyme or reason.
There isn't.
There is no rhyme or reason about how they do it. We get a different amount from Cigna. I'll go back to them. Every time we get a check from them, it's a different amount.
Yeah.
It just doesn't matter. We're not able to say, hey, it's plan A, plan B, plan C. It's just like, yep, Cigna shorted again, like they do. Yeah.
And
So-
they don't even, I don't even think they'll call it a usual and customary, so it's where it's a consistent amount. It can be all over.
Yeah, like they couldn't even argue that we're saying, no, we're only gonna reimburse 200% of Medicare, because that's not how it calculates out. It's not even, there's literally no rhyme or reason. It's almost random from those vendors. It's a constant battle, and that's the whole problem.
Now, do you find that this Cigna and United is is that a small amount? Like Medicare and Medicaid is probably the largest, but then I haven't dealt with Cigna or United. I mean, I've heard of more of HMO Blue and things like that. So is this a small volume?
So the volume of dollars on the commercial side is much higher than the volume of dollars on Medicare and Medicaid
Yeah.
in the system. Because what all systems have to do is revenue shift to the commercials, because The Medicares and the Medicaids pay below cost. And so everyone revenue shifts to do that. So the Blues of the world, the Bay States plans, Cignas, all of those commercial plans end up paying much higher rates to offset the lower dollar volumes from Medicare and Medicaid.
Okay.
So we completely revenue shift the system to offset the numbers. Because you get the payer mix every month, right, on the 15th? That automated email that comes out?
That's the one that we have there's an app you made for the computer for that one?
Yeah, the
Yeah.
Tableau stuff.
Yeah, I haven't looked at it in a couple months, but yeah.
Yeah, so we have it all automated, all the data through Tableau, so we can pull that up and say, okay, this is what's happening, and this is what the system's looking like, and it's very interactive.
Well, it was, and Molly kind of talked about it before, Mike. The reason why I was questioning some of it is because it seemed like it went down less. I mean, we didn't do the full amount, so it seemed like your revenues were down, so that's why we didn't get the full amount back. But my office is right at the end of the street, so I see it out every day, all the time. You are so busy, so I didn't understand. Maybe it was a collections issue. I was just questioning what the history was, why there seems to be less this year. You know, it's going down rather than up.
It ultimately comes down to the payer mix.
Yeah.
So you can have some commercial plans, but you can have a lot of people on the Health Connector plans as well. Those are Medicaid plans too.
And there's allowable rates on those or something like that,
It's
right?
Medicaid only. Yep, and that's it. So it really comes down to the payer mix. And if you have a shift in payer mix, it's gonna show revenue either go up or down.
Okay.
So there's two factors. It's payer mix and it's call count.
Call count? Oh, yeah,
So-
the volume.
And it's not responses, it's transports.
It's transports.
Transport. So do you find you're getting more and more people that refuse transports?
So in all of our systems that we run, only 70% typically of the calls that we respond to result in a transport. That's a pretty clear number on all of our systems across the board.
Is that an industry number-ish for this
Pretty
area?
close, yeah.
Between Amherst, Northampton,
It's pretty close.
pretty
yeah.
close?
Especially with high motive, if you would have more and more MVCs, a lot of people refuse at MVCs as well too, especially low
You do
velocity.
any charging at all for non-transport?
We can't. It's not reimbursable at this point in time.
The only way the only way we bring in some revenue on that is if, for example, but it's difficult to process it all. If there's a massive amount of oil, so if they blow out an oil tank or something, it's not antifreeze and all that stuff. We can bill out under that 21E
Yeah,
section
the hazmat.
for that, but it's usually the antifreeze rather than the, so it's.
We'll get you a whole payer mix from the beginning, an analysis, and we'll share that.
I'd love to
with
see spreadsheets.
you. Yep, we'll get that for you.
Yeah, because it does look like you're down from last year about $250,000. Because your billables last year were $1,419,000. So
Well, you can't go on the gross number. You have to go on the net number.
What's the
Oh, I'm sorry.
That's the net charges.
Oh,
Yeah.
okay, all right, I'm sorry. I'm thinking of a different report that we have.
Okay.
Yeah, we'll get the analysis though,
Okay.
and
Yeah,
match it out.
okay.
And you need it fiscal year, right? It's better fiscal year or
It's better
calendar?
fiscal year, yeah.
Okay, that's
Yeah.
what I thought.
Yeah. And then for comparative, same time frame. That'd be good. Any more questions specifically on the numbers? If not, I was just gonna, so now this is the look back, so this is the end of FY '24. Anything different that you're seeing other than, with UMass finally moving us up on the, or Amherst moving us up on the cards? Other than that, is there anything different you're seeing in FY '25 that would impact projections?
From a volume perspective,
Mhm.
nothing that comes to my mind, but CMS did approve, I believe it was a 2.4% increase in Medicare and Medicaid rates
Okay.
as of January 1st. So
January 1st, '25.
January 1st, 25, yeah.
Okay.
So there'll be a small increase
Yeah.
just in that reimbursement. But beyond that, I'm not aware of anything else that's coming into play yet.
I mean, Deputy and Chief, do you think that Amherst volume is going to remain?
They expect, the warning that they gave to me when I sat down with the chief, the interim chief, was that you can anticipate between 150 to 180 calls that they're normally giving to Northampton.
Yep, that's going to be your impact, which is already starting to kick in.
So, and again, if you're the only, I mean, it's going to fluctuate because Northampton has multiple ALS ambulances,
Right,
you know what I
right,
mean? So if you
right.
guys are at an Amherst call, there are times there's 2, 3 mutual aid ambulances coming in, which they don't want to call our BLS unit at this point. So we're working on that as well.
Like today, our ambulance was there, Action, and then Northampton was literally right behind them for mutual aid.
So you probably won't see that full 150, 180, but you'll still see probably a minimum of at least
Looking at 10 a month.
75%.
Looking at 10 a month.
Potentially, yeah, especially with the students back.
Yeah.
So that'll fluctuate up and down based upon,
This one.
And then possibly missing calls here during that time.
correct then, yeah,
Right.
so,
That's that downflow. That's the domino effect of mutual aid.
right.
Right.
Oh my God, yeah.
Well, and we already got warned with the whole Palmer ambulance thing closing, that Amherst is going to be getting stretched out to.
They're gonna be backfilling Belchertown and Ware, so Ware, Belchertown, they're all gonna be trying to figure out who's helping out. You know, Wilbraham's gonna be trying to help out covering now, because Palmer Fire just started their BLS unit. So, you know, they're struggling. They actually requested your contract to get eyes on it, because I know you're in Hamden. So there's just concerns that it's gonna be a domino effect with Palmer, the private ambulance, or their, nonprofit ambulance that they had there, that shut their doors.
So I met with them last week with Palmer about
Palmer Fire or
Palmer ambulance,
Mhm. Yep.
about what was going on.
And I'm sorry, Palmer Ambulance was a private,
Correct.
okay.
Nonprofit.
Not yet.
Not for profit. Yeah.
So their background is they lost about 3,000 calls a year from Wing.
When that show.
When AMR took it over. And that was the beginning of the problem right there, is that they lost all that volume. And Palmer, the town, did not want to subsidize them to offset those
And
costs.
AMR took over because of Bay
Yeah,
State?
Bay State,
Okay.
yeah. So that's how it played out. So, the impact has not hit us as of yet from Palmer, from our Hamden and/or our Tri-Town area. But we go to Wilbraham all the time in that shared arrangement with that regional dispatch center. So the jury's still out in terms of how often. Palmer did reach out to us, Fire, about an intercept agreement, but we don't know if it's gonna work because the hospital's right in town. Right? So
Yeah, what do you
we're going
intercept?
multiple towns away to intercept with someone that has that has the hospital right in town.
Mm.
So they're just gonna, pick up and go most likely. Now, Palmer Fire can't staff their ambulance either. So there are some days that they don't have coverage from what I understand.
Yeah, I haven't heard all the details on that, but I think that's why they were looking at your contract to see if, I don't know if they're gonna reach out to you and ask you for support on it. I don't know, I've spoken with the chief multiple times, and I know he wasn't anticipating this, this changeover. I think he was trying the phased-in approach. It just, when the doors closed, then.
They were thrown into it.
Yeah, so.
Yeah. Yeah. So that's a little bit of the background.
Okay.
Yep.
And then, I guess another question for you would be, it's been a while since we met. I know staffing's always a conversation, but kind of from your standpoint, what's working, what's not?
So the future's looking a lot better than the past, would you say, Chief? In terms of,
We got some good news, yeah.
we've got some good news. So weekends have gotten a lot better. Dominic Singh, who is the region EMS coordinator, is coming to work in the system as well to shore up the system. He's coming here.
Which is huge.
Which is a big thing. So big advocate. So the schedule is tightening up nicely for us. Yeah. So our paramedic program's continuing to run. We've got 9 students in the program altogether. We have 3 on the east side, and we have 6 on the at Berkshire Community College, where they're doing classes there as well. So our feeder system is starting to look better as well as we push them through the program, which is good news. Anything else?
Actually, we can just jump into it too, but we had a verbal agreement on the contract through June 30th of 2025. So we just wanted to discuss maybe our next meeting, if we could sit down and start discussing how we're going to be moving forward. And you'll hear about our plan for our truck, but it would be a conversation with you. We're going to need your support in our transition, because it's going to be a while before we, we're working towards it, but we want to continue our partnership. But I want to make sure that that's going to work for you as well.
Okay.
So,
Yep, let's understand the plan,
yeah.
right?
And we can give you some information. Obviously we've been tasked by the town to really start moving forward, implementing our ALS service, but we just finished our 1 year of BLS. So, and staffing is certainly not easy, but we did meet with Dr. Morse today to try and make sure, and we presented to him that we are making sure that our foundation is solid here, because he's the golden gatekeeper. If he's not comfortable with our service going out on the road, then it doesn't, because he's the one who signs our prescription.
He's tough as nails.
What's that?
It's tough as nails.
He is,
Which is good.
Which is great,
Yeah.
and but I think he doesn't show it, but I think he's very excited and happy that we're moving forward. Dave has been tasked with a 3-month plan to start working on making sure our ALS license is in, ready to go, and then we had told you that the hope was by June 30th of 2025 that we would have our truck inspected, ready to go, so that we could then start doing ALS for our second calls. So backing up action at the ALS level, so that we can start getting our feet wet, making sure that we have the time we need for all of our folks. There's going to be a time period, I told you, where we are going to need to ride double medic with our new employees. That's going to be mandated by Dr. Morse. The good thing is, with bringing Dominic on, to have an extra set of eyes, and that's what I wanted to talk with you also about, was maybe a per diem shift with some of your folks that assist us with some ride time on our truck, to be those mentors for our new folks and getting eyes on it. So those are all part of our plan to see how we can move forward. But as of right now, we're probably talking a minimum of, we told you it's probably going to be a year before we can fully go with our model here.
Mm-hmm.
So that's why we wanted to just discuss that transition plan. If it's a phase down where it's not like we want to phase out action. We want action to be here to support us, but at some point we're going to have to do that transition, or else we're not going to be able to self-sustain our department. So, and I'm under the gun, because the funding right now, it's not a budget. It's funded by free cash. So they've been very nice about supplementing with free cash, and this year they're going to do a capital stabilization to get us through June 30th. So that's our budget is being funded on right now. So town meeting, we're hoping that they'll approve that.
It's a loan.
Yeah, as a loan. Oh,
Yeah.
trust me. Need to know when we're paying that back. So.
Hey, I'll vote for that this year.
Thanks, Joyce.
I just think the cup is talking.
So our BLS ambulance, we've gone to well over 50 calls now, second calls. And I just went over the ALS service, if anybody has any questions about that before we move on.
You just reminded, the only other question I forgot to ask before is, and it's kind of related to the, initially it was just action, and then we got our BLS up and running, and then now we're actually, during certain time frames, you're running out of North station,
Mhm.
right, instead of central station.
Hmm.
So I had asked Mike at one point, do we have any data, has there been any degradation in response times because of that? Or are
Negative.
we,
Yeah, I'm
We've
not
reviewed
seeing
that.
it.
Okay.
No.
All the
Okay.
response times have been
Yeah.
great.
okay, just
And
wanna make sure.
'Cause they
again,
can
they come here during the day,
Mhm.
or if they have, like today, for example, they were doing restocking and inventory up there.
Mhm.
And I can tell you that the way I look at it is our response times are still cut in half from what they were, even if they were, the worst case scenario for us is a call on Skinner Mountain if they're up
I
north.
was just say Hawk
Or Hawk.
Mountain, yeah.
We had one incident. It was they were a BLS crew because they dropped down no medic, and it was just they were unfamiliar with the area, and that was a one-off situation.
And
Which
I
we
called the
reviewed.
supervisor that night, and
Yeah.
I was listening, and everything was taken care of right away.
And then the other thing that you have to remember is we are now licensed, our engine is now licensed as a EFR. So
BLS EFR.
BLS EFR. So our truck going there has all the equipment as if
Equipment
we
that
were
we need,
sending
yeah.
our basic ambulance.
Mhm.
So they are gonna
We
be
can start-
doing,
We can
they're
start
gonna be
BLS
doing,
treatment up to
Yeah.
meds and everything.
so it's not, it's just, and again, we've had some calls in North Hadley where, serious ones, in the center of town, where the 2-minute and 30-second response time
Worked out
from North
better.
Station was amazing.
Yeah.
So
I mean, I would imagine, I mean, given the location, shooting over Stockbridge and
Yeah.
down,
they're
right?
beating us to Greenleaf.
Greenleaf's.
So-
Yeah,
Yeah, I did get one person came and mentioned to me that it took, which I was surprised, which there's probably more of a story, but they said they called because it was an elderly person in their 90s that was at the Most Holy Redeemer and fell.
We reviewed it.
We just reviewed that.
That's the one? Okay.
It was a 6-minute response time. And
Okay.
3 minutes of it was dispatching, or 2 minutes
Okay.
and 30 seconds.
The actual truck, the
That
ambulance and
didn't-
truck got to the same time. It was a 4-minute from time they were dispatched to the time they were on scene.
Yeah,
Okay,
and
of
I'm
course
gonna-
they told me it was 15 to 20.
Oh, yeah,
Well, no, that's fine.
what I felt like.
And I was called,
I knew when he started talking about that.
I was called and asked to review it, and
Okay.
I haven't even had a chance to reach back out to Kathy to get back to her.
It always seems that amount
It does,
longer
yeah,
you're waiting for that
of
ambulance.
course.
Yeah.
which is good news, you know.
Yeah.
Yep.
I'd rather point out where we weren't wrong than try and explain why we were wrong.
Right, exactly.
For once.
Yeah, and again, just speaking of response times, one of the things historically the committee's done is just if they're, you know, you and Evan are looking at reports, if there's anything over a 10-minute response time, there needs to be an explanation. So is that process all?
Yep, it goes to Dave.
It goes to me.
Yeah.
Dave checks our CAD first of all, and checks with action, and if it's something, it goes out to Emma, our
Usually
supervisor.
Usually it stops at our CAD because because action communicates with our CAD. If whatever our CAD has them logged in at, it usually stops there because I can say, okay, then it's a key and error on action's part when they generated the report or whatever
Right.
happened.
Yeah,
Or when they call
just
their
the data.
dispatch.
Exactly.
Yeah,
But
And
our
that-
dispatch is time stamping everything, so that's
Yeah.
what Dave looks at. And
And what we do is, data entry errors happen all the time just because of the pace of everything, so we'll go back and look at GPS data. That's the most accurate.
that's- yeah.
We can tell when the truck starts,
Mhm.
we can tell when it starts to go in motion,
Mhm.
and then we can tell when it stops, and so they'll do that for verification of the GPS system, which that's the most accurate method of checking.
And then again, we had one today or yesterday, but it was a call to the top of Skinner Mountain.
That
So
was-
that's gonna be automatic, it doesn't matter where they're coming
Yeah.
from in town
Yeah.
to get up the
I think it was like
winding
an
road.
extra
It's-
like 3 minutes.
So,
yeah,
so,
yeah.
so those are the ones we just kinda cross off the list. Or, you know, wintertime, you know, if we evaluate,
Right.
they have to drive up to North Hadley and it's 6 inches of snow on the ground, you're not gonna get there in 10 minutes.
And no out of chute issues, personnel, everybody's good, they're
If anything, I think it's improved,
great,
so.
good. Good. Is everybody happy? Ish?
Happy-ish, yeah.
Next,
Yeah, you gotta keep it to an hour, Mo.
That's right. Yeah. Right. So, anything more we need these guys for?
No,
Or-
but
I mean, you're
you're
welcome to stay,
stay.
yeah.
I'm just
Yeah,
looking
think
forward
about
to
it.
seeing the numbers after, so that way we have an idea when he's asking us for, like, you know, down the road, what to expect. I kind of want to know what our history is and
Sure.
where our numbers have been
Yep.
and what the history is, yeah.
Yeah, and COVID throws everything.
Oh,
Yeah, so
You gotta
anything
pull it
after
out.
COVID, you know, I get that COVID
Yeah,
went down, but
Yeah,
but
so
after COVID, you've been
23
busy.
Yeah, it's,
You
we
started
had
going right up.
we had two COVIDs, really.
Yeah.
We had the major one, then we had
COVID.
a mini one that fall of 22.
22, I thought.
No, that was 21.
Acosta.
We'll
be
check
able
the
to-
call
we'll
volume.
be able to tell.
We can tell, but things died
I
for a
did
few
think
months.
FY 22 for us.
Oh,
Right.
yeah.
That's what we-
Oh.
FY 22.
Yep.
I think it was the time frame. So those 2 years of data get skewed a bit,
Okay.
unfortunately.
Mike, is it possible for them to get on that system? Are we allowed to?
Yeah,
Okay.
just
I think
share the
Molly-
link.
I think
Yeah.
you had it right for the.
Tell 'em what.
I've had it.
Yeah.
But I
Yeah,
don't
you
always get it.
Yeah.
So.
No, it's the
okay.
same link.
It's the same. So you just click on that.
Oh,
It
I
always-
see. So
it's
don't wait for
updated.
another email.
Yeah.
Yeah.
It's,
All right,
it's
I
the
get it.
live-
There
it's the
was
live
there was a
document.
few error.
Okay,
It
thank
was
you.
throwing an error code probably about a couple weeks ago.
Oh, just let me know.
I clicked on. It was like error.
Okay, I was in it yesterday.
Okay.
So I know
All right.
it was there.
Do you want to send it out to? Could you send it out to Evan, myself, and Dave, and then we'll forward it to everybody? Or
Yeah, that's fine. Evan's got it too.
Okay.
He was checking it.
So we can just forward that link to
Oh
whoever.
yeah, it's live.
Okay.
Yeah.
Yeah.
Okay. That
So
makes
anyone
sense.
can look at it, like anyone you share it with.
Okay.
The October data is not updated yet. We haven't gone back and looked
Sure.
at the October data just because of the date.
Does everybody
So
want to look at that,
it'll
or
pop in.
does everybody want?
Yeah.
Okay.
And then you just have to walk into the reset, Evan.
I think that was
line,
my.
the
Yeah.
line down the bottom. So when they start clicking and things start changing,
Oh, right.
to hit the reset button to go back to start again instead of unclicking everything. It's so interactive that if you look at a day a week, the data that will populate is just for that particular day of the week. All the response times, the call counts, what hospitals they go to, all the complaints. And then if you end up picking a day a week and a time, it'll only look at those data sets. It's that interactive.
There's no.
It's really cool.
There's no personal. Info.
No, there's
Right.
no
Okay.
HIPAA,
Right.
no protected,
Okay.
no protected data in it at all, specifically for this,
Right.
to be able to share it.
Just numbers.
A lot of numbers. Yeah.
All right, great.
Everybody's heard
Okay.
about the request we've made for the purchase of that Adams ambulance. Has everybody been watching the town meeting?
Yeah.
We were very fortunate to. They're being very generous.
I didn't see it, Mike. What, is it in good condition?
It's a 2022. It's in very good condition. Basically, it looks exactly like Action's ambulance. And we were fortunate. They were actually asking for $86,000 to start just for the ambulance. And we kind of expressed to them what we were doing and gave them an offer for the ambulance, a new power cot, so the cots that lift up by themselves, the bottoms lift up. We got a Life Pack 15, which we just purchased a new one that was 50 or 40 something thousand.
49,000.
49,000. We got a stair chair that's 4,000 or 3,200 or something like that. Basically, the cost of all the equipment they gave us is more than the cost of the ambulance, and they gave it to us for 70,000.
Ooh,
So the only thing it needs on it is some new tires, which we'll have as part of that budget.
And it
And
pays
an
you off.
affirmative vote at
Why?
town meeting.
rid of a 22.
What's that?
Why are they getting rid of a 22?
They closed their doors. They went out of business. That's Adams Ambulance Service.
Oh, wow.
And then the association stepped up and they purchased an additional. They had 3 Life Pack 15s, and the association stepped up and bought one to donate to the town for an additional 5,000. And they're throwing in a bunch of other equipment for us, and we're actually looking at a couple other pieces that are quite expensive to purchase that we're going to need as part of our ALS build out. So.
I'm gonna
Great.
need to update the special
Great.
folder on insurance.
I'll vote for that.
Make sure
Next
you
week.
show up.
I'll pick you up and drive you there if you need.
Yeah.
Maybe I can find a bike.
Actually, we did want to ask you, I have to come see you about a couple other questions on this.
That would be great.
So what else you got, Mike?
That's, unless somebody else has new business or anything, questions? I can tell you, we also had talked with Dr. Morse about the ambulance doing some, if we do get the backup ambulance, about doing some calls.
Oh, yeah.
So
yeah.
we're working on that. They do have a contract, but we are gonna look into if there's a way if we can be a backup or some sort of a help to that
Right.
with scheduled, transports and
Right.
stuff like that, so.
He likes the idea, they've entertained the idea before, but it's never really worked out, as he said. And more so because a lot of departments aren't in the position to lend that staff to do that work. But if we can make it work for local, and we can make it work for, returning patients from the hospital to our nursing home or to Amherst nursing home or,
Well, that's something
it's fun, it's
Yeah.
money coming in.
then there's some number of people, like you're saying, who they have to go, whatever. I mean, I would think you could plan on those in advance.
Mhm. Yep,
Yeah.
yeah, so it's a discussion with Hadley and Elaine as well.
Yes.
So, because that's a different thing, them going out versus them coming back. So
Mm-hmm.
I understand they have that contract, but we just said that if they're overwhelmed and they need a resource, it's not gonna be our staff leaving. We're not having firefighters that are on duty, we're not having,
Right.
the ambulance. This is a backup ambulance for us right now, because we don't have enough staff to, we wouldn't have
Who
enough
does
staff.
most of that? Is that national?
Right now, it's
Pioneer
Pioneer.
Valley.
Pioneer
Valley,
Valley does,
yeah.
okay.
For
They've been
for
transporting.
CDH,
Yeah.
but national for Hadley and Elaine.
Oh, okay, I was just gonna say, because
Yeah,
when
'cause
my
you see them,
father-in-law
yeah.
was there, it was always national that got him.
But they haven't been really able to give them an ambulance, so they call 911.
Yeah.
Yeah. Yeah.
You still doing that?
Yeah. Not as bad.
Yeah,
It's
it's
gotten
not-
better.
Okay.
That's all I had.
All right, and I think, I have not forgotten, we had talked about the chief, you and I possibly just getting together a little bit less formally at some point to just have some conversation about the,
Yeah, that's fine.
yep. Mike loves coffee. We can get him when he's not fighting brush fires.
Just don't say it.
I'm
Don't,
trying to talk him into
don't
that.
say Don't say it. We've been. Say we got us nervous.
No, don't even.
Just because they said the wind wasn't supposed to be bad and the wind was ridiculous today.
No.
They shut the Mass Pike down.
Yeah,
I'll show you.
They had a bad fire in Chicopee. Brush fire.
Oh,
So they
no.
shut the pike down.
wow,
Amazing.
wow, that's
Hey, we
crazy.
got rain coming,
On,
really.
on Sunday,
Yeah, a little
right?
bit,
Yeah,
not
But
enough.
him and I went up to the ponds today just to, because the
Just to let it-
college kids like to party up there. So want to make sure there was no pallets or anything. And
Yeah. No farmer, or no Hadley residents burning trash in their backyard.
Oh, we had a close one today.
Mhm.
We'll just keep it quiet.
Yeah. I heard about one potential, so.
Be careful.
All right,
You're
somebody
on
want to
camera.
make a motion to adjourn then?
Make a motion.
Okay, is there a second?
Second.
All right,
Aye.
everybody in favor? Aye. All right.